the social workers, chaplains, they all really work together to support this serious illness and the patient and the family. Hospice can be provided in the home, nursing home, or briefly in hospital. But the 24-hour care is still up to the family. And with hospice care, because of how it's reimbursed, many insurances don't cover room and board in a nursing home. There's wonderful things to hospice, there's wonderful things to palliative care. But palliative care is more of an umbrella term that covers dealing with serious illness. Hospice, on the other hand, has to do with the end of life and dealing with people who have a prognosis that's usually less than 6 months. And many times, since people aren't ready to say no to life-prolonging therapies, hospice care is very short. The Center to Advance Palliative Care has created a diagram that shows us that when someone is diagnosed with a disease or a serious illness, early on, palliative care might not have a big role. The focus is really curing or restoring that person to their prior health. But as that becomes less and less able to be achieved, palliative care gets more involved. And when they get to the point where they're saying no to life-prolonging therapies, hospice is appropriate. In Trinity Health, we have a vision for palliative care, that everyone impacted by illness will have access to comprehensive palliative care, and that the relief of physical, emotional, social, and spiritual suffering will be achieved. This compassionate and holistic care will be provided throughout the journey of living and dying. It's not just for the dying. It's really dedicated to all people who are dealing with serious illness. And what we realize is that in order to improve death, we must begin where death occurs. We have to put a face on the suffering, understand what's going on with that patient and their family, and then truly be with them. Each person is sacred, and we feel that so strongly in our own ministry. And we realize that you have the opportunity to make a difference in suffering, one patient at a time. But you need to understand how people die. There's different ways people die. There's sudden death by accidents, heart attacks, miscarriage, neonatal loss, unexpected suicides. If you think about that, it's very difficult. You don't have any preparation. But what you have is a complex grieving situation. And those of us in healthcare have to create ways to support these families who go through sudden loss. Probably the most common way people die in the United States now is that it's not a really long illness. It's a short illness with a rapid decline. People are older, they might have a few chronic problems medically, and then they have a stroke, they get a pneumonia, they get an infection, they come into the hospital, and they die. Hospice was originally designed for people that we could look at and tell that they're going to die. Progressive illness with predictable timing of death. This is a very common thing that hospice was set up for, that there are certain types of cancer we know are terminal, and that we know it's likely to be less than a few weeks or a few months. When we know that it's going to be predictable, it's easier to get people into hospice type care. But most people, it's not predictable. Most people live with chronic illness, such as chronic lung disease, congestive heart failure, or Alzheimer's as they get more elderly. And these illnesses many times have crises that look like they're going to die, but they don't. They come in and out of the hospital a lot. They could die, but they don't. So if we are going to really create systems to support all these types of illnesses, we not only have to figure out the hospice model, which is for people that we know what's going to happen, we have to create access and systems that support all these other types so that dying well will be possible for everyone. Because everyone, doesn't matter what their serious illness is or what their situation is, we have multiple access points developed, we'll be able to support them. Within Trinity Health and Catholic healthcare, there are ethical and religious directives, and we are directed to be a community of respect, love, and support to patients as they face the reality of death. This is an important message, an important directive that we take very seriously. And those of us that are from the Christian faith realize that we have an opportunity to reduce suffering as well as a mandate to act on compassionate reduction of suffering. The ethical and religious directives tell us that what is hardest to face is the process of dying itself, especially the dependency, the helplessness, and the pain that often accompanies terminal illness. And we're mandated in healthcare to make a difference. Pope Benedict, in last year's World Day of the Sick, had a message for all of us in healthcare. He talked about palliative care. He said palliative care was very important and that there's a need for more palliative care centers which provide integral care, offering the sick the human assistance and spiritual company they need, and that the right belongs to every human being, one which we must all be committed to defend, to not suffer before they die. I've created materials that I think will be helpful for those of us that are going to take on this commitment to help others deal with serious illness. I call it the 3 sacred truths. Now that you understand, we've spent quite a bit of time talking about the suffering at end of life or those with serious illness. Let's talk about what we can do to change that. The first sacred truth is that there may be suffering with serious illness, but it doesn't have to be related to pain or physical symptoms. Pain can be managed. We're able to get all our patients' pain scores down to 1 or 2 before they die. We're always able to manage pain. My teachers have been my patients. This is Angela. Angela was diagnosed at 20 with malignant melanoma. It's a type of skin cancer. This is her wedding day. I had followed her already for 5 years before this time, and she died a year after this. She is my teacher. One of the things she taught me was the suffering that we create in our patients when we don't understand how to manage pain. And the ignorance that exists when people believe that using stronger pain medicine, such as narcotics, will create drug addicts. This is probably one of the most common things people are afraid of at end of life. They're afraid to take pain medicine because they think they're going to be a drug addict, which is so untrue. She had a very complicated pain syndrome, and she couldn't take oral pain medicine. Now, we managed it very well by teaching her how to give herself injections, and she did for the last 2 years of her life. But do you know how she was treated when she went to a pharmacy or she carried her pain medicine around or maybe even went into the hospital? People thought, because she had all this Dilaudid, all this pretty strong pain medicine, that she must be a drug addict. She didn't look that sick. The judging, the ignorance creates terrible pain on top of the pain they already have. In the Bible, John 13:34, it says, I give you a commandment, love one another as I have loved you, so you also should love one another. This is how all will know that you are my disciples if you have love for one another. More than anything, pain can be managed, and we're mandated, God directed us to love one another. We can manage pain, but we have to do it in a way that honors them and helps them and doesn't judge them. This is another one of my teachers. This is Miyoshi. She had bilateral amputations of her legs. She was on dialysis. She was only 49 years old when she died, the same age as me in this picture. I took care of her for almost 3 or 4 years. Do you know how many times she'd go to an ER with a chronic pain problem because she had a chronic infection in her bones and had just terrible pain? And she'd go in there asking for pain medicine and people called her a drug addict. Do you know how many times her family and friends would question her use of pain medicine? It created a huge stigma for her. And more than anything, she wanted people to understand how important it was to get her pain under control. She says, when my pain is okay, I can do a lot of things. People look at me because I have no legs and I'm pretty sick and I've lost my hair, and they don't think I can do anything. And I can't if I have a lot of pain. But if my pain's under control, I can do a lot. And she lived with terrible illness for quite a few years before she eventually died. And she taught me a lot about strength, and she also taught me a lot about the untruths that so many people believe as it relates to pain management. We're also instructed to bear each other's burdens. We're not supposed to create burdens. We're supposed to bear each other's burdens. And we need to do that by just getting knowledgeable about how to manage pain. This is not something just doctors and nurses need to know. Every person who's caring for someone who's dealing with pain should know the truths and untruths about using pain medicine and managing pain. And part of this presentation, you will receive a booklet that goes through the truths and untruths of pain management. We must aggressively combat the untruths. We must search out the right support and treatments. And we need to not make more suffering by our own ignorance. Some of the common untruths I'll talk a little bit about, such as sick people at end of life will become addicted to pain medicine. That is absolutely untrue. Less than 1% of all patients on narcotics become addicted. This is so important for people to understand. Another untruth is that if you take pain medicine too soon in the course of your illness, it won't work later in your illness. I can't tell you how many people think that. And that, again, is not true. There's always effective pain medicine available. Many people think they'll get too sleepy, confused, or be unable to think if they're on pain medicine. And that, too, can happen, but we can adjust the pain medicine or go to something else. There's always ways that we can make pain control possible and thinking possible at the same time. There is a lot of suffering with pain, and many people feel that suffering is something that they have to do, that's even God's will at end of life. And although God certainly talks about suffering as part of life, He also expects us to be wise and care for others like Jesus did to reduce suffering. There are things we can't control, and people will have sufferings when they get sick. But it doesn't have to be related to physical pain. Many people think if they take narcotics or pain medicine at end of life, they'll actually die quicker. Actually, the studies show people live longer if their pain is better managed. They can move around better, they can prevent other complications, they can get out of the hospital quicker if they take pain medicine. One of the greatest untruths is that all doctors know how to manage pain. That's just not true, just like all nurses don't know how to manage pain. Most doctors receive little or no education as it relates to pain medicine. Most of them have to learn it themselves. But there are specialists available, and there are important ways that we have given you in the booklet to find a pain specialist. More than anything, don't let the untruths lead you to suffer, either if you're dealing with a serious illness or you're trying to help someone else. And there's many more untruths in the booklet. Please take the time to study it and understand it. And be, please, a truth teller, not an untruth teller. In Matthew it says, I was ill and you cared for me. Whatever you do for one of these least brothers of mine, you do for me. Sacred truth number 2 talks about that there will be suffering when you have a serious illness, but it doesn't have to be related to lack of understanding of the illness, what the treatment options are, or even the prognosis. So many people don't really understand what's wrong with them. The studies we showed you previously said that 75% of people who are dealing with a serious illness really don't understand what's going on. It's interesting, in the Psalms it talks about that 70 years are given to us, and some may live to 80, but even the best of these years are often empty and have pain. Soon they disappear and we are gone. It challenges us to teach us to number our days and recognize how few they are. Help us to spend them as we should. So many times in the Bible it talks about that we need to become more and more in knowledge about a lot of things about our life. For some reason, we can understand how to run a computer, or we can understand how to drive a car, or we can understand a complex math equation, but we don't really take the time to really understand our illness. We kind of ignore it. We kind of let other people make our own decisions. Or we just think the doctor will make all the decisions. It's very important to get good information and to really understand what's happening to your body so that you can understand the pros and cons of trying to prolong your life or the pros and cons of different treatment options. One of my special teachers was a lady in her 30s who was dealing with serious cancer and then on top of that had a stroke. You see her here with a couple of her children. She came to our hospital not really understanding that she was at end of life. But it was very difficult to talk to her about it because there was language issues, there was a lack of clarity about what she'd been told previously by other physicians, and there was a lot of family getting very upset about even trying to talk about all of this. But it's so important to understand and help people understand so that they can make good choices. With this lady, once she understood how sick she was, she wanted to go back to her country and die with her parents. This was kind of complicated, but we were able to achieve it. But we would never have gotten to achieving her last wish if we hadn't really tried very hard to help her understand how sick she was. Sometimes people are given the wrong message. This is one of our teachers who was told he was dying, actually went into hospice and he didn't die. And he was like, well, what's going to happen to me? I'm not dying. Well, sometimes you don't die when it's expected. And I think it's real important not just to talk about how seriously people are ill, but also talk about, well, maybe there are